Good afternoon. Good afternoon, everyone. I'm really pleased to welcome you here, to welcome the folks that are here in the room, and to also welcome our audience that are joining us via remote connection. My name is Greg Keefe. I'm the Dean here at the Atlantic Veterinary College, and I'm so pleased to be here to have this inaugural lecture today. So I want to extend a special welcome to our guest speakers, Dr. Barry Maron and Dr. Étienne Côté, our own Dr. Étienne Côté. They'll be introduced more fully in a few moments. I also want to extend a very special welcome to Dr. Eric Butler and Mrs. Suzanne Rocca Butler. They're longtime supporters of AVC, and it's their great love of animals that has really kind of brought us to this moment here. They currently, as I'm aware, are the owners of two cats, or the cats own them. We're not really sure who drives the bus there. The cats are Hermes and Oliver. It's really been Eric and Suzanne's vision to bring this symposium to light, so we're really excited to do that. They approached us a couple of years ago to initiate this, and the idea is that we will have a regular conference focused on the commonalities between veterinary medicine and human medicine. So this is our inaugural event, but we really do hope that we will continue along with this in a series of lectures in the coming years. The Butlers became very interested in the concept of zoobiquity, an approach to medicine that explores connections and commonalities between humans and animals. The concept is based on a 2012 New York Times bestseller with the name Zoobiquity, the astonishing connection between human and animal health. And this approach explores how understanding medicine issues in animals and humans can benefit both. Their interest in zoobiquity is really timely in our view because of the One Health movement that's happening in veterinary and human medicine. The One Health initiative defines One Health as a broad-based symbolic umbrella of public health, veterinary and human medicine, and ecology. So we're able to host this symposium with the support of the Pegasus Family Foundation through the Silicon Valley Community Foundation. I think I'm moving your slides along. We'll figure that out. I can give the talk as well. Oh, good. I'm still doing it. So Eric and Suzanne established the Pegasus Family Foundation in memory of their beloved cat, Pegasus. They adopted Pegasus when they were here at their summer home in Prince Edward Island and took him to their home in California. Sadly, Pegasus died at the age of 9 from respiratory failure associated with cardiomyopathy. They also lost another cat, a Pip, at the young age of 4 from the same disease. So you can see that the topic today has a deep personal connection for the Butlers, and we thank Eric and Suzanne for supporting this project and for their wonderful support of other initiatives at the AVC. So I'm now going to call on Dr. Lynn O'Sullivan, who will moderate the symposium and introduce our guest speakers. Lynn is a veterinary cardiologist and professor here at AVC. She's actually a member of the AVC class of 1998. She's a board-certified cardiologist certified by the American College of Veterinary Internal Medicine. So I want to thank Lynn for acting as moderator, and Lynn, the floor is yours.
Thank you very much, Dr. Keefe. Good afternoon, everyone. It's such a privilege to have Dr. Maron here, and so I'm really pleased to be a part of this event. Dr. Maron will be our first speaker, and then that will be followed by Dr. Côté. And then we'll have a question and answer session at the end to close. For the listeners within our live audience here, I would ask you to use, obviously, the microphones on the side in the aisles. And I'm apparently advancing the slides as well. And for listeners online, we would welcome you to text your questions to 902-394-3860, and that number will be posted on a slide at the very end. You're also welcome to email your questions to AVC One Health QA@gmail.com, and that email will be posted on a slide at the end as well. I'd ask everybody to please silence your devices, your cell phones. And should the seats fill up here, although there still are plenty at the front, there are overflow rooms next door in Lecture B. And so now it's my pleasure to introduce our speakers. Director of Medical Research at Tufts Medical Center, Dr. Maron, will be well known to those involved in medical cardiology. Considered the world's foremost authority on hypertrophic cardiomyopathy, he's authored or co-authored over 800 peer-reviewed publications, including over a dozen consensus statements and guideline papers. During his distinguished career, he's been awarded many honors, including the Physicians' Heart and Stroke Award from the American Heart Association, the Lifetime Achievement Award from the European Society of Cardiology, and the American College of Cardiology Distinguished Clinical Scientist Career Award, among others. Professor of Cardiology in the Department of Companion Animals at the AVC, Dr. Côté is double-boarded in veterinary internal medicine and cardiology and is a 3M National Teaching Fellow. He's the editor of several books, including Clinical Veterinary Advisor and the preeminent text in the field, Textbook of Veterinary Internal Medicine with Stephen Ettinger and Ed Feldman. So please welcome me in please join me in welcoming Dr. Maron to the stage.
Okay, thank you very much. Can you hear me? Is that all right? Well, good, we're back to the beginning. It's a pleasure to be here, really, because I've been interested in cross-species cardiac disease, particularly hypertrophic cardiomyopathy, for 30 years, when I began an association with the Animal Medical Center in Manhattan. And we've continued that. We've written a number of papers on HCM and other diseases that occurred in cats and dogs that replicated the human disease. So I think it's important and it's of interest. And I'm going to tell you today what hypertrophic cardiomyopathy is in 2019. A lot of this will overlap with what Dr. Côté is going to talk about in cats and possibly other animals. But there's a lot here that doesn't have a current application to veterinary medicine. It may in the future, but I think this is an opportunity for me to tell you what HCM is in the patient population, see if there are any applications that we're not aware of at this time. The first point to make is that not only is this a common disease, we've been able to identify it really throughout the world. There are 122 countries that claim hypertrophic cardiomyopathy. You see, the pointer's not working. Okay. Yep. Top button for the pointer. Oh, okay. Well, you know, Greenland's been in the news, so I thought I'd point that out. I've always wanted to go there. This is, we updated this slide, actually. We found, believe it or not, Eskimos with HCM in Greenland. So if the disease, which by the way is well known in Iceland, if it's in Greenland, it gives you some idea that it's all over the world. How that happens, I've never had anybody really smart explain to me. That a disease that looks pretty much the same everywhere is all over the world. Genetic disease to boot. Now, the prevalence is as seen here. We've done prevalence studies. It's one of the only diseases like this that actually has any data that documents prevalence. The initial cardio study said 1 in 500. That was with echocardiography for the phenotype. More recently, if you make estimates including the occurrence of sarcomere mutations in the population that are disease-causing, familial occurrence, gene positive, phenotype negative, family members, all of that together, you can estimate a prevalence that's actually closer to 1 in 200. So that's a lot of patients with hypertrophic cardiomyopathy. United States, that would mean that there's over 1 million. At any one time, though, only about 100,000 can be documented clinically. So that leaves a lot of affected individuals that are not known to be diagnosed with the disease. Some of them could be high-risk patients subject to sudden cardiac death. These numbers of 1 in 500 are achieved in a variety of studies from different places in the world and different study designs. So I think that these numbers are real. And this is a relatively common disease. It always has that problem. It's common, but the less common diseases seem to be better known. And this has a big impact on the patients and information and grants and all kinds of things. How is it that this happens? There are a variety of reasons, I'm sure. But, you know, when you think about cystic fibrosis, well known to everybody, ALS, Lou Gehrig's disease, the multiple sclerosis, these are very, very uncommon in the general population. And HCM is a disease with much more impact on the population. So you're probably all familiar with this idea that it's a thick heart with asymmetric hypertrophy, septum bulging in the left ventricular outflow tract and all of that, asymmetric distribution of wall thickening. And that's often the case. It's a lot of variability. Our basic definition is that it will be hypertrophy, let's say with echocardiography, 15 millimeters or more, in clinical practice in the absence of another disease, systemic or otherwise, that could produce that magnitude of hypertrophy. In other words, unexplained left ventricular hypertrophy is the disease for diagnosis. Now, the 15 millimeters, though, that's a nice number to hang on to. It's very useful in clinical practice. But we are seeing patients with this disease that have less than 15 millimeters for sure. We have operated on patients with left ventricular outflow tract obstruction that had wall thicknesses of 10 to 15 millimeters, in fact. That involves a different kind of operation, but nevertheless, there are exceptions, in other words, to this definition. And of course, the end stage in which the left ventricle remodels and thins and gets more dilated, that type of progression may produce a heart ultimately that doesn't meet this definition. I also have family members that have a so-called mutant gene, no left ventricular hypertrophy at all, and they are part of the disease spectrum, but they don't make this definition. So this adds to a lot of confusion about what HCM is, since there isn't a single definition, perhaps, that's neat like that. At any rate, when you look at the muscle, there's been a lot of attention to what the histopathology is. These disorganized cardiac muscle cells at oblique and perpendicular angles are probably related to the unstable arrhythmogenic substrate and ventricular tachyarrhythmias, probably. Of course, the disorganized cells are not evident in clinical examination, so it's a supposition. There is a small vessel disease, and that may lead to microvascular ischemia, and then lead to cell death and scarring as replacement and repair. So those are the histopathologic hallmarks of HCM, reasonably consistent, but identifiable, again, only at autopsy. So to get to a clinical disease, there are some rules that make it easier to understand. The heterogeneity is enormous. I already alluded to the fact that some patients don't really have much hypertrophy but have outflow tract obstruction and appear to have the disease. There is this clinical unpredictability that goes through the disease spectrum. And a lot of times when we have to make clinical decisions on patients, we just do not have absolute certainty. So a lot of judgment and experience may go into that. I'll talk about that in a minute, related to risk for sudden cardiac death. I'm not sure exactly how the cats come to recognition all the time, but this is what usually happens with the human patients. A lot of times they are recognized because the onset of symptoms can be chest pain, impaired consciousness, shortness of breath, of course. That can do it. There are routine examinations such as family screening, all kinds of other circumstances. A lot of times now, HCM is identified in older patients because of other things. CAT scans being done for chest pain and all kinds of other situations to get patients into the arena, and then some imaging test demonstrating HCM, which was completely unknown at that time. So we have a lot of older patients with new diagnoses as well. So the heterogeneity gets you to this idea of the patterns of left ventricular wall thickness. There's a lot of variability from mild, as I suggested, almost no hypertrophy possible, to extreme versions of hypertrophy. The areas of wall thickening can be virtually anywhere, usually at the base, there, basal septum, sometimes at the apex, where it attracts a lot of attention for uncertain reasons, but is not a separate disease entity. It's just segmental hypertrophy, which can be just about anywhere. But this is what attracted us to this early on. It's been a long time. The original paper in circulation with Phil Fox at the Animal Medical Center, who was one of the first, I guess, to routinely or frequently image the cats with echocardiography. And the images, you'll see, are very similar, that basal septal hypertrophy, then anterolateral hypertrophy, more symmetric hypertrophy. It's the same phenotype. That's the thing. How can that be, that cats have the same phenotype as this disease in 122 countries? That's the interesting thing here. So talking about what it means to have HCM, the first point to make, that we do make for patients, is that this is a disease compatible with normal life expectancy and longevity. That's the first thing I say to them, and I'll show you the data that supports that for just about any patient, or at least the vast majority. And when we look at our cohort and follow the patients, and we've done a lot of outcome research to see what the disease means over time. This is in a tertiary referral center, and about half the patients or more, nothing happens. They're not treated in any particular way often, certainly no major interventions. It's very common to see patients in their 50s, 60s, 70s, and even older who have had no consequences of hypertrophic cardiomyopathy for all that time. The disease has left them alone, okay? And may not be clear why that is, but this is an important part of the population, and I assume this is also true in veterinary medicine. You know, it is what HCM is. Sometimes it's not much. But of course, we're here for the patients also who have complications of the disease because we're responsible for treating hypertrophic cardiomyopathy. Most common problem, which is the most common problem I think in veterinary medicine, is heart failure. That heart failure in our population is due to left ventricular outflow tract obstruction almost always, 90% of the time. There is atrial fibrillation, which I'll talk about later, which occurs in about 20% of patients, symptomatically at least, probably occurs in about 50% of all patients at some time or another, either subclinical or overt. Very common arrhythmia, the most common. This thing about sudden death, of course, is the most visible part of the disease spectrum, the thing that everybody knows about and worries about, and that we're charged with addressing, as I'll show you. But in numerical value, sudden death events are the least common complication of HCM in a population, at least a tertiary referral population. So this is the disease, and we start to talk about management. There are basically 4 profiles of sudden death. Heart failure, usually due to obstruction. It can be heart failure associated with non-obstructive HCM. So non-obstructive heart failure, obstruction producing progressive heart failure most of the time, and then atrial fibrillation with that risk of embolic stroke. Now, you know, you've probably all heard about this connection between HCM and sudden death on the athletic field. Again, this doesn't have a direct relationship to veterinary medicine, but it's an important part of the disease because HCM is the single most common cause of those athletic field catastrophes. It's not more than 50%. There are many other conditions that have the propensity for sudden cardiac death, but HCM is an important part of that picture. These are undiagnosed individuals who are out there usually in competitive sports, often intense sports and training, who often get in the newspaper because of the event. So that this idea has perhaps overblown the risk of sudden death related to hypertrophic cardiomyopathy, although it is real. You know, these are some very famous athletes. The idea here in this collage is that only 1 of the 6 actually died suddenly of HCM, a member of the San Francisco 49ers. But Gathers, that's cocaine. Maravich, coronary anomaly. Hughes, coronary artery disease, atherosclerotic disease. Heat stroke. And Bias, cocaine. So there are many reasons for these deaths to occur in athletes. HCM is one of them. When it happens, it's big news, okay? And sometimes it is hypertrophic cardiomyopathy. Now, again, talking about sudden death, this is not, again, tightly linked to veterinary disease, but just to tell you that we have a risk stratification algorithm. Any one of these features of the disease can lead to high-risk considerations and the possibility of a primary prevention implantable defibrillator. This is a very important new, by new I mean 20 years, approach to HCM, and I'll show you the data. Now, the risk factors are varied there. I didn't go through the list, but one of them is massive hypertrophy. There's no other disease that does this. I assume there are cats with HCM who have excessive hypertrophy, and that has been a risk marker for us. This is about 40 millimeter septal thickness when our normal is around 10. This is intuitively something that would be a risk marker because there is a relationship between increasing wall thickness and increasing risk. And the arbitrary cut point that we use is 30 millimeters. Can be itself an indication for an implanted device prophylactically. So hypertrophy itself counts. And that allows me to make a point about MRI, another modality, again, which is not part of clinical practice in veterinary medicine, but just to show you what it can do for the phenotype. This patient with echo, there is some mild thickening of the anterior lateral free wall, enough to make the diagnosis, but that's about it. In a plus-minus quality echocardiogram, applying the CMR to the same patient, it turns out that this area is actually very thick because the epicardial surface is not really defined. But it is with MRI, the epicardial surface is way out there. So now we're talking about 32 millimeters and enough for a risk factor for HCM. Patient becomes eligible for a primary prevention ICD because of the MRI. Okay, now most recently, the left ventricular apical aneurysm has turned out to be a finding that is a legitimate risk marker and can by itself be a reason to implant a prophylactic ICD. If anybody here has this finding in a cat with HCM, that would be a paper, again, showing the confluence between the species. This is what they look like in patients. They can be large or small. Sometimes they have a clot in them. They're thin-walled, outpouching at the apex. So it's a left ventricular apical aneurysm. And sometimes associated with left ventricular outflow tract obstruction that's muscular. But the important thing is this. This aneurysm has a clot, okay, so anticoagulation is indicated. But the area of arrhythmogenicity is in the border zone at the base of the thin aneurysm. And that can be identified with contrast CMR as LGE. And this is where the monomorphic ventricular tachycardia and VF come from. So the aneurysms for us are a direct indication for implanting an ICD. And again, I would be of interest whether, have you seen this before? You've seen it? All right, so we have a paper. Because, you know, there wouldn't be any reason for that to be there unless it was part of the disease. what you would do in managing cats with aneurysm is another question. But again, it links the two. And of course, it's a high-risk feature, and we've demonstrated that repeatedly. In human cardiology, MRIs become very important. Contrast MRI showing these areas of late gadolinium enhancement that can be in various places and in patterns. Turns out it's very common. So the presence of LGE tells us almost nothing, just the presence, a lot of times small areas. Now we had this experience several years ago at the beginning of our experience. We happened to image with contrast CMR a 18-year-old who was very innocent looking, asymptomatic, and all of that. And lo and behold, he had this bright stuff in the ventricular septum. It looks like a scar. Now, we had no data, but we did a brilliant thing. We decided that that probably was not a good thing and implanted an ICD. 9 months later, he had this event. There's the shock for VF. So a life-saving shock, and it's like 20-some years ago, he's still alive and normal. At that one moment in time, one moment, but the device was there and restored sinus rhythm, and that led us obviously to do studies in populations. And what we have found is that the presence of LGE, again, by itself doesn't mean anything, but extensive, more extensive LGE becomes higher risk. So that when you get up to around 15% of left ventricular mass, that's LGE or scar occupying 15% or more of the mass of the left ventricle, that risk is unacceptably high and itself can be a reason to implant a defibrillator. So these are all changes in risk stratification that have occurred recently. The other recent thing, and this could matter, again, to veterinary medicine, there's an anti-risk factor down here, and that's aging. And by that I mean that our patients, once they get to 60, 65, and certainly 70, with or without risk markers, have very low risk, no different than what you would expect in the general population. That meant that there is a protective effect by age, somehow, part of the disease, and it has discouraged us from implanting for primary prevention patients based on age, meaning more than 60, 65. There are exceptions to that, of course. The aneurysms can be an exception to that, but generally speaking, aging is good, and this is what we tell the patients, that age decreases risk for an event, sometimes even with risk markers. Now, I got this far and I haven't said anything about mutations. And there's a good reason for that. You mentioned mutations earlier today and how you felt bad that you didn't have any. I'm going to say that maybe there's no reason to feel bad about not having any in veterinary circles. There are at least 11 genes that have been placed as pathogenic, with mutations among them of more than 2,000. So there are a lot of mutations. They're not all disease-causing, and all of that changes a lot from day to day. So the whole thing is kind of dynamic and changing and making it difficult to know what to do with these data. Now, here's what we do. Trying to incorporate this in, genomics into clinical practice. Well, first of all, the mutations have absolutely nothing to do with prognosis. That's very clear. There is no such thing as a bad gene and a good gene. And knowing the mutation should somehow tell you what is going to happen. So that's been cleared up, almost certainly. Over here, patients have thick hearts, relatives or otherwise. There is no information that you need about those patients from genetic testing. They have the disease. Where we use it is in families where there can be a situation where children or offspring have normal echoes, MRIs, but the proband, let's say the father, clearly has the disease. Is there any way that that child or offspring has in fact inherited the gene or the susceptibility to HCM, even though the echo is normal? And of course it's possible, and we have a whole slew of individuals who we call genotype positive, phenotype negative. That means they have a sarcomere gene, but the phenotype is not there. We can't see hypertrophy with either the MRI or the echo. What about them? That's a whole group of individuals. I guess theoretically they're susceptible to develop the disease. That's the argument that's been used by the molecular biologists. But that doesn't seem to happen very often. I mean, we have these individuals that are in their 50s and 60s and haven't developed hypertrophy or anything else. And we have hundreds of these patients and we never had one event. This is an event-free group, no development of symptoms, heart failure, or sudden cardiac death. Is it a disease? Probably not the way that some would think of it, but we need longer follow-up, obviously. This has led me to say this. This single sarcomere mutation hypothesis is now 35 years old. It was pushed as the answer for the disease. If you knew the mutation, you would know everything that you needed to know. Somehow or another, patients would arrive in the clinic with a, something you could put into a machine, that had everything that you needed to know for management. That clinical medicine was obsolete. I heard those things a while back. But the reality is now, after 35 years, there isn't a single patient, not one patient who's benefited from the sarcomere mutation hypothesis. Not one. No one has had the quality of their life improved or their life saved. There are no examples because it doesn't work that way. Now, on the other hand, and I worked at NIH a long time ago, we were told that the clinicians were no longer needed. This was all going to be over on this side, And clinicians were called chart reviewers, if you can imagine. And it still amazes me when I think about that, being called a chart reviewer as a lower form of life. But that's what was going on. These things take off like that. And all the data that I've shown you so far, and that I will continue to show you about modern HCM is solely from clinicians and clinical scientists, with absolutely nothing from this side. It's an important principle. In fact, now we're wondering whether this mantra that the sarcomere mutations cause the disease is even true. Now, why would I say that? Well, it's not hard to say that. If you take, 100 probands who have the disease, established disease, without question, and you genotype them. We do commercial genotyping now, it's very easy. How many of the 100 probands with HCM would have a pathogenic mutation? How many? It's right there. 30%. 30%. So 70%, this is a genetic disease, and 70% of the patients who have the genetic disease don't have a pathologic mutation. So that does raise questions. It's not to say that the mutations don't track in families with hypertrophy, they do. But, this is really a much more complicated story with very little application to the kind of data that I'm going to show you. So I apologize about talking about prevention of sudden death, because I'm not sure in 2019 whether this has a lot to do with what you can do in the clinic, veterinary clinic. However, to give this lecture without talking about this would be a mistake, I think. This is the guy that's responsible for the implantable defibrillator. Michelle Morawski was a Holocaust survivor, the only one of a family of 24 who did survive the Holocaust. And he went to medical school, and he got this crazy idea that about putting in a permanently implantable device that would be ready to overturn lethal arrhythmias. It was a crazy idea. In fact, Bernie Lown was the most famous cardiologist in the world at this time. He, in New York, in Boston, and he commented in this editorial. I think you might be interested in seeing this because it talks about, what it means to be ahead of the game or thinking out of the box. Lown said there wasn't any evidence that if you had VF, that you would have it again. Hard to believe that he said that. If you found a patient that had an ICD that was dead, then how do you know he wasn't electrocuted? Hard to believe he said this. So, you're all thinking, how can Trump say these things? Well, not to defend him in any way, of course, but, there's a question of whether there would be an indication to use, such a device, even if it worked. What would the indication be, he's saying? So, smart guy says it's an imperfect solution in search for a practical application. Well, it's the single most important advance in cardiovascular medicine in our day. So even the experts can be wrong. So when you decide to do something with the cats and everybody says you're crazy, you can't do that, tell them about Morawski and Lown. So we tested the ICD anyway, we have a large registry, and we found it to be effective. That it very often appropriately shocked for VT-VF in high-risk patients. Gave us a primary prevention annual shock rate or intervention rate of about 4% per year, and that's held up pretty well. As the population has gotten more diluted, then that 4% drops down maybe to 3%. But anyway, the point's still made that the ICD works in this population. These are presumably patients that are alive who would otherwise be dead if it wasn't for the device, in most cases. And then recently we published this paper in JAMA in which my son Martin's clinical group, with some collaboration, made these decisions about ICDs over a 17-year period. Does the patient have sufficient evidence of high risk to deserve a recommendation for an ICD or not? Okay? So this is sort of a prospective application of, in real-world setting, of prevention of sudden cardiac death that you wouldn't get in a registry. Turns out there were actually 82 patients that had life-saving shocks and were alive because of the decision to implant them with ICDs. Then the other question was, well, who didn't get an ICD and what happened to them? And there were 5 sudden deaths in patients who did not receive or had an ICD, 5 versus 82. But you have to look at this. Actually, of the 5, 2 declined the device, decided they don't want to have it, and paid a price. 2 had no risk factors, and this can be true in HCM, that you just don't have any evidence of increased risk at that time. So I think that this made the point that you can, in almost all patients, prevent sudden cardiac death. I mean, that's a big difference from many years ago. This risk can be almost obliterated with the individual risk factors. So what happened was the number of sudden deaths decreased because of the device, and that brings forward heart failure. So let's talk about heart failure as a cause of death and morbidity. The obstruction, the left ventricular outflow, causes progressive heart failure in patients. Most of progressive heart failure, as I said, is due to obstruction, mechanical impedance to left ventricular outflow. And there you go. This is also from the Fox paper. Replicating the mechanism, systolic anterior motion, mitral septal contact associated with mitral regurgitation, small outflow tract, they look the same. The phenotype is the same even when you go to obstruction. So in the patient population, obstruction is very, very common. 70% of all patients have the propensity to develop obstruction either at rest or with physiologic provocation, meaning exercise. So you've got rest obstruction, provocable obstruction leading to 70%, just leaving about a third of the patients who have the non-obstructive form of the disease. And this shows you what happens when we subject patients who don't have obstruction under resting conditions to provocation, which is treadmill exercise, what we call stress echocardiograms. And there are a lot of patients that get big gradients that don't have them at rest. And these data are actually predictive because If you have a big gradient with exercise, about 3% per year of those patients will then go on after that to develop progressive heart failure symptoms. So obstruction counts, okay? Obstruction counts a lot in this disease, just like hypertrophy counts. And here's the example of the stress echocardiogram. Normal velocities at rest, no SAM, and then raising the heart rate. This is basically what we do. We raise the heart rate, mitral septal contact, and a big gradient with exercise. This can qualify a patient for surgical myectomy, which is this. This is obviously an operation that cannot be performed in small animals, but is the preferred surgical approach, in patients at this time. There are not that many expert myectomy surgeons around, and that's really a key limitation. It's not a standard operation for a variety of anatomic reasons. But one thing I wanted to point out was that a lot of times obstruction is produced by anterior mitral leaflet that's excessively long. And when this happens, the myectomy channel may not be enough to prevent postoperative systolic anterior motion and mitral septal contact. And it's up to the surgeon. What they may do is they may put a suture in that anterior leaflet to prevent it from having the same mobility. And the suture will prevent the valve leaflet coming forward in systole and making contact with the septum and producing obstruction. This is an operation that could be done without the myectomy muscular resection, because it's the valve that produces obstruction when you really get down to it. Now, these are data from Mayo in collaboration, which show the long-term consequences of surgical myectomy, their large program. And this is the general population and the myectomy population for total mortality. And they're the same. So the inference is that there is a long-time survival benefit from reducing the pressures in the left ventricle, getting rid of the obstruction, in addition to improving the quality of life. So the operation is done to reduce symptoms or obliterate them, has a survival benefit as well, and now is a low-risk, high-benefit operation, where at least 90% of patients benefit significantly in terms of their symptoms, associated with a mortality that's somewhere around 0.5%, which is the lowest of any cardiac operation at this time. So what about non-obstructive disease? That's no gradient at rest or with exercise provocation. And non-obstructive disease is favorable in general. Only 10% of those patients will develop progressive heart failure. But should a patient fit into this 10%, then there's trouble, because this is where it is only the heart transplant that remains as a definitive option. Again, not applicable to veterinary cardiology, really, but just so you know, that heart transplant is a treatment for non-obstructive, severely symptomatic, progressive heart failure that's refractory to all other measures. So this always raises the question, would you rather have obstructive HCM or non-obstructive? If If you have non-obstructive, you've got 90% chance that almost nothing is going to happen, with some exceptions, but can be very benign throughout life. But if it also comes with this risk, and then you really have problems as a heart transplant candidate. Over here, with obstruction, okay, there's much more chance that you're going to develop progressive heart failure, but there is a treatment that will reverse heart failure by reversing the obstruction. Two ways to look at the disease. Now, you may be interested to know, again, giving a little historical part to this. Dr. Brunwald really started this whole thing at the NIH in early 60s. First real description of HCM that they called IHSS, or idiopathic hypertrophic subaortic stenosis. He's almost 90 now, and he's still going. He's at Brigham and Women's. Former chief of medicine. Now, the reason this guy is sitting with Brunwald is that this was the first patient diagnosed with the disease. Dr. Brunwald diagnosed him, obviously without echo, without anything but a stethoscope. Mr. Brady is almost as old as Dr. Brunwald at this point. The interesting thing is that this is Mr. Brady's heart, going way back. And you can see that it is scarred. This is what the end stage looks like in HCM. Dilated, scarred, non-obstructive. And this is where the possibility exists for that 10% that I showed you here. Okay, Mr. Brady's still alive because he benefited from a heart transplant. 80-something, 85, I think. I haven't mentioned atrial fibrillation. Now, this is in the cross-species discussion. This probably is different than anything else relative to the cats, I think. Although apparently cats with HCM can develop atrial fibrillation. It doesn't sound like it's very well worked out or described. Very common in patients, as I said, 20% with symptomatic atrial fibrillation, another 20-30% with asymptomatic picked up on ambulatory monitoring. It's probably half the patients have the propensity to develop some atrial fibrillation, very, very common. We treat it with antiarrhythmics. If the paroxysmal episodes are too frequent, there's an option for catheter ablation or a Mays procedure if they're also eligible for surgical myectomy. With these modern treatments, paroxysmal atrial fibrillation is really a quality of life issue. Quality of life. It's not a mortality issue. There's a really low mortality also in this group associated with atrial fibrillation, something around 0.7% per year. Particularly if the patients are compliant with anticoagulation. And now with the NOAC drugs, this becomes a pretty easy thing itself. So we've pretty much eliminated fatal embolic stroke in this disease by using those drugs. Anything's possible, but basically they're gone or going. So the threshold, the starting anticoagulation is low, 1 episode, paroxysmal atrial fibrillation. Now, I wanted to sort of finish up by showing you that everything I've been talking about as far as management has actually occurred. It's not just talking. We have a model for this in the Tufts cohort of about 2,000 patients. Okay, so if we start this way, remember this is a 17-year thing. We used to think of HCM as having a mortality of about 2% or more per year. That's mortality, 2% or more per year. That's before ICDs. So in this cohort, there were these ICDs and their interventions, which dropped the mortality to 0.8%. Then if you add the transplants for refractory heart failure and non-obstructive disease, the mortality drops to 0.6%. And if you add other things like out-of-hospital cardiac arrest and hypothermia, survivals, this is where we get our 0.5% per year mortality associated with the disease. That's the human situation. And it's about the same relative to different ages, including younger patients where the risk is supposed to be higher in adolescents, children, and young adults. Still about 0.5% per year for mortality. And in the cohort, we think there's an argument here that 161 lives were saved by these treatments. It is literally a new day. So these are paradigms, something to try to achieve, I guess, decreased mortality and morbidity. This has become a treatable disease, extended and normal longevity associated with the decrease in mortality and also decrease in morbidity. These treatments do something that we only dreamed about a long time ago, and that was change the clinical course of HCM. They changed the clinical course. So you've got the ICDs over here. You've got drugs going to interventions here for obstructive heart failure. Non-obstructive disease and heart failure has only one definitive approach and doesn't happen very often, transplant. And over here for atrial fibrillation, the anticoagulation, most important, and then antiarrhythmics and catheter ablation for frequent PAF. So to sort of summarize that way of thinking, I was thinking one day not too long ago about how, the oncologists were bragging about how they have reduced mortality in cancer. And how much money that cost. That whatever they say they've done, NIH and other money, to do that. And I thought, wait a minute. Our mortality is way down here at the bottom. It's way lower than the cancer. Cancer is way up here, 6%, and we're 0.5%. And nobody talks about that. And we didn't spend any NIH money to get that. Trust me. So it turns out that if you want to talk about mortality, whether it's annual or 5-year, in a new treatable disease, just about all the other risks that we all have here, cancer, diabetes, just about everything's on this list, kidney disease, all much higher than HCM. So in summary, HCM is the most common monogenic cardiovascular disorder. Prevalence could be as high as 1 in 200. Still, nevertheless, under-recognized clinically. The disease is heterogeneous, has a very broad clinical spectrum, but a worldwide distribution affecting all races, ethnicities, genders, age. It's probably the single most common cause of sudden death in young athletes, but those are individuals not evaluated clinically, almost certainly. All the disease-related complications are treatable, as I've spent a lot of time explaining. Heart failure is reversible. Can't say that about any other form of heart failure. Heart failure due to obstruction is reversible in this disease with what has become low-risk, high-benefit surgical myectomy. The overall disease mortality is far less than 1% per year. It means that we can tell patients that they have a disease, if we treat it, that is consistent with normal or extended longevity, often with, or usually with, good quality of life. And all of this has meant that there's been a conversion from a pharmacologic management to these more modern interventions and aggressive treatments. The drugs, the beta blockers, verapamil, disopyramide, they are old. None of them after 35 years. In other words, there hasn't been a new drug for 35 years. And they don't affect the natural course of the disease, and they do, in and of themselves, do not lessen the risk of hypertrophic cardiomyopathy. So it's a new day and a non-pharmacologic approach to the disease. Thank you.
Thanks. Thanks. Okay. All good? Dr. Maron, thank you. If this is meant to follow in the shoes of giants, then I'm an ant in a size 38 Converse, I think. This is a great privilege, and it's my pleasure and my honor to try to follow that, with a bit of a veterinary perspective that you have so kindly already alluded to. So I'd like to talk about feline hypertrophic cardiomyopathy, zeroing in on cats, even though dogs, pigs, and other animals are known to have spontaneous hypertrophic cardiomyopathy, just not with the same prevalence and not in as widespread a fashion as cats seem to. I want to start by thanking the folks that invited me here and made it possible for this remarkable seminar to happen. Thank you to Eric and Suzanne for having the kernel of this idea and then bringing it forth so that we're actually here today. Dr. Maron, I can't thank you enough, and it'll be an unforgettable piece of my career that I somehow got to share the stage with you. Thank you for being here. The Atlantic Vet College, the Dean's Office, and Janice, your unbelievable work to make the day happen today are incredible. And my colleagues on the cardiology service, thank you as always. What I'd like to do as we go through these different sort of aspects of hypertrophic cardiomyopathy, beginning with the human and the veterinary and delving into them individually, is maybe to hark back to what Dean Keefe mentioned initially, which was he referred to One Health as a concept that integrates or that twins veterinary health with human health and maybe brings in as well environmental health. So One Health has been defined as the integrative effort of multiple disciplines to attain optimal health for people, animals, and the environment, and that together the three make up this concept. That's the American Veterinary Medicine Association's definition. It's also a similar one that's used by the Centers for Disease Control. And it was brought to my attention that just this week a large grant was made to the University of Wisconsin from the National Institutes of Health, the NIH, in support of a One Health initiative. So this is something that perhaps over time has evolved. I remember when I was a kid, a pet animal was, a dog that was on the end of a chain in a dog house in the yard. And the idea that that animal would come in the house was maybe not always seen so favorably. Nowadays, the folks that I work with, my clients who bring their pets, often consider their pets to be a member of the family. This is a societal evolution that we have undergone. And so it is that today then our attention to companion animals in our society has also generated very interesting and very useful information from the veterinary medical standpoint. And as Dean Keefe mentioned early on, it was Dr. Barbara Natterson who sort of brought this into the public eye with the publication of a book called Zubiquity that juxtaposed basically these essentially identical disorders in animals and humans and brought that to light. And I think many of us veterinarians kind of knew that because we extrapolated a lot of what we knew and did from more advanced human techniques and greater knowledge. But the idea of bringing it full circle to physicians and then back to veterinarians, I think is new and is part of what today is about. So we didn't actually set this up, Dr. Maron and I, but I would ask in a similar way to what he said, which is the cat and which is the human? So on the left is an image from Dr. Braunwald's atlas, one of his many textbooks, that shows a postmortem specimen of a human heart demonstrating the demonstrating the marked septal hypertrophy characterizing hypertrophic cardiomyopathy in this patient that passed away from the disorder. And this is a cat that I saw back in Boston with similarly, maybe not quite as impressive, but clearly abnormal thickening of septum, free wall papillary muscle, and with that basal septal bulge that was surely responsible for dynamic obstruction. So if I think of what are some of the hallmarks of feline hypertrophic cardiomyopathy, I know that certainly what we've just seen on these pictures is in common to both humans and cats, a non-dilated, hypertrophied left ventricle, a heart that is thick. We also know, though, that looking a little closer histologically at the microscopic level, that there are additional lesions and that these are shared by humans and cats alike. So interstitial fibrosis, the bluish discoloration seen between the cardiomyocytes in this view here, and myocardial fiber disarray, or this disorganization of the tissue of affected patients. These are two cat specimens, and so this I think shows nicely how similar, even at a microscopic level, how the two disorders are similar. But in their clinical expression, they are similar as well. So I've positioned this lateral radiograph here like a human radiograph is usually positioned for familiarity to physicians and nurses and medical students who are tuning in. The idea of diastolic dysfunction of a thick ventricle that is unable to accept blood into it well enough to move it through is certainly one of the hallmarks of advanced hypertrophic cardiomyopathy. And as is shown in this feline patient, that can lead to cardiogenic pulmonary edema, congestive heart failure. Finally, we know that feline hypertrophic cardiomyopathy is an active process, and that's demonstrated by measurement of blood-borne biomarkers. These are substances that, like a ripe fruit on a tree, would be the first to fall off if the tree is shaken, and so likewise, cardiac troponins are detected in the circulation of cats in abnormally high concentrations when those cats have hypertrophic cardiomyopathy causing respiratory distress. So these are the concentrations of troponins here in such cats compared to cats that have the same degree of respiratory distress but for some other non-cardiac reason. Now, what I like about this list is that it illustrates some of the rather detailed similarities, if not identical characteristics between our species. So at first blush, the fact that the ventricles are thick in both species with this disorder is intriguing. On closer inspection, it becomes fascinating. Now, for the next slide, what I'd like to ask is for your input. And I'm mindful that those of us in the room here can respond to me visually, but I'd actually like to invite everyone in this room, as well as anyone else who is tuning in through live streaming, to participate in this poll by using your phones or computers. So here we go. I'd like to know which of the following best describes you. So who are you? And these are the categories you have to choose from. And the way to answer is, the easiest is to text. So this is me. If you text to this number, 37607, and the number you put in is my login, which is ECOTE768, then you have access to this poll. And I'd like to ask you to do that, please. That's anyone in this room and anyone else who's listening in. It's totally anonymous, and I just want to have an idea of who's tuning in. So when you do that, bring up your text, dial in punch in 37607, and then write in Côté, and you'll have the choice. Just put in one letter, A through G, and we'll see who it is who's listening in today. I'm not sure that there's a competition element, but it would be nice to know. All right, so far so good. Physicians have disappeared altogether. Let's see if we get them back. Any others? You can also go through your web browser if you're just online with your laptop or a desktop, and just go to polleverywhere.com, type this in, and away we go. All right. Maybe we'll give it another second or two. The reason I'm asking is because I'm curious to understand the perspectives, and I think this will be especially interesting when it comes to the question period afterward. All right, let's wrap it up. So thanks to those of you who answered. There isn't, of course, a particularly right answer here. This was for my own information. So let me then steer maybe the conversation towards, or the monologue, frankly, towards this specific sort of path. So what I'd like to talk about are the following high points, and if we manage to cover bits of these in the next 45 or so minutes, then I think we will have a reasonable starting overview of hypertrophic cardiomyopathy in cats. So I'll talk a little bit about its prevalence, meaning how widespread is it, what is its impact, similar to what Dr. Maron expressed about human patients. And then how do we know, right? Presentation, I mean, the cat doesn't complain of chest pain, so how do we know that we have this disease? How we confirm it, and then what we can do about it. I'm especially interested in additional species differences and our own remaining unanswered questions. Maybe that'll dovetail into question period afterwards. So here we go. So the prevalence of hypertrophic cardiomyopathy in cats can be described as shocking. The reason I say that is because population survey after population survey has shown that 15%, 15% of cats have hypertrophic cardiomyopathy. This can be in a referral setting of a teaching university hospital that shows almost exactly this percentage, or it can be in the setting of shelter, where cats that are being housed in a rehoming center or a shelter are all systematically echoed. And depending on the exact cutoff, so we too, as you were mentioning, Dr. Maron, have millimeter cutoffs for defining hypertrophic cardiomyopathy. there's, I think, some ongoing discussion about the optimal one, but even the more conservative cutoffs bring in a prevalence of about 15%. Now, that's a lot. And if we consider that in North America, there are 90 million cats, then a prevalence of 15% is enormous. In fact, putting those two numbers together and considering that that brings up 13.5 million affected cats or whatnot, it then becomes surprising that they're not all dying like flies. And of course, that brings up this concept that you raised, Dr. Maron, that perhaps there is a subset or even a majority of cats that have this disease that live a perfectly normal life without knowing that they have it. It was Dr. Phil Fox from the Animal Medical Center who put together a very large retrospective multi-center study, 42 institutions in 20 some odd countries from memory, just published last year, called the REVEAL study. And in it, he looked at the outcomes of 1,008 cats with hypertrophic heart disease compared to 700 odd apparently healthy cats. What these cats had in common, they all got echoed and they all got followed up for 5 years or more. And that's pretty good. For us, an old cat is a cat in its 20s. So a follow-up of 5 years is very substantial. And what's interesting to note is that these cats were all subclinical, so-called asymptomatic, a term we don't use too much in veterinary medicine because if a symptom is expressed or spoken to the clinician, then we never get that. But subclinical in terms of cats showing no overt evidence of disease. We had to go looking for it with an echo. And so out of these 1,000 cats that were followed up for 5 years or more, and many of them 10 years or more, what Dr. Fox found was that 27.9% of them at some point eventually died of hypertrophic, obstructive or non-obstructive cardiomyopathy. And that was essentially almost 30 times greater than the occurrence of death in cats without heart disease over that same follow-up period. So that's shocking. It means that I'm 30 times more likely to die of hypertrophic cardiomyopathy if I have it than to die of anything else if I don't. And at the same time, the glass half full says that this means that these are cats with this diagnosis, oftentimes in years past, who might have been given to a cat owner with no understanding of medicine, a diagnosis with a gigantic and horrible sounding name, where perhaps it sounded like this disease diagnosis was some sort of doom, death sentence. And in fact, 70% of these cats live a perfectly normal life, or at least go beyond the period of follow-up. So this was tremendously useful information because it didn't exist either to this magnitude or with this depth and degree of follow-up before. And what it tells me is that as a veterinary clinician, I'm mindful that even though I may have an individual cat who has this diagnosis, the rate at which it evolves and the likelihood of it causing problems for my patient are highly variable. To your point, Dr. Maron, there are risk factors that have been identified in cats with hypertrophic cardiomyopathy, including massive left ventricular hypertrophy and particularly left atrial enlargement, as high hydrostatic pressures seem to indicate worsening diastolic dysfunction, at least to us. So what does this mean then in terms of recognizing this disease for us as veterinarians? The clinical presentation of a cat with hypertrophic cardiomyopathy can vary. I'll point out here that the retrospective study that produced these numbers was developed at a tertiary institution, so it might underrepresent the proportion of cats that have no clinical signs. But certainly the occurrence of congestive heart failure, of aortic thromboembolism, the so-called saddle thrombus that forms when presumably a blood clot forms in the left atrium, is expelled into the arterial circulation and lodges at the aortic. We don't have a bifurcation, we have a trifurcation because cats have tails. And so that so-called saddle thrombus is a recognized and very devastating aspect of hypertrophic cardiomyopathy. So if that's true, if this is sort of how these patients present, how do we know that? I mean, if they're not complaining of shortness of breath. So here's a video clip of one of my patients from a couple of years back. And I have it on loop because I'd like to draw your attention to the subtlety of this particular clinical sign. So here to loop again in a second. Cat seems pretty darn comfortable. The setting is, this is a carrier, which was, how the cat was brought in. It normally has a roof the same color, and we just unscrewed it and peeled off the top half. This is in a cage, so the cat is unbothered. And like a true cat, this individual is unperturbed by the world because he knows that the world is at his command. And what I'd like to draw your attention to is that despite this demeanor of seeming relatively comfortable and alert, the side of the cat's chest, the sides are clearly moving out with maybe a little bit more of a prominent excursion or a greater degree of effort than we might normally expect. A subtle finding, and yet a critical one. Here's another cat. This cat's on our echo table, looking at me, sort of making hand gestures behind the phone as I'm trying to film this cat. And this is just a cat who's not impressed and gives the general sort of impression of leave me alone. If we look a little closer, we can see that both at the thoracic inlet and also the front of the chest and the sides, that there is a greater amount of movement than might be expected. This is a cat with what I would describe as a moderate degree of dyspnea. This cat was about 2 minutes post chest x-rays, and those radiographs that we took were these. So this is this cat over here on the left, and again I've positioned this to look a little bit like a human radiograph. So this is this cat. This is a normal cat for comparison. What I'll draw your attention to is the pronounced retraction of the lung lobes from the body wall, essentially the effacement of the whole superior and anterior area here, as opposed to here, caused by large volume pleural effusion. Same cat, more familiar view. And so what we see then is that a remarkable degree of compensation and of not letting on is a feature of cats in general, and certainly cats with congestive heart failure. We can speculate about how maybe this evolved and how cats that did show their overt clinical signs were preyed upon in the wild, over the centuries and millennia. The bottom line is that this illustrates how challenging it can be sometimes to identify this abnormality and make this diagnosis. So perhaps then it isn't surprising that HCM is so widespread in cats, even though they're not always rushing to our doorstep. So what do we know then about confirming this? And here I'd like to ask for a little bit of input once again. So for those who have already contributed, thank you. Please pull out your devices or bring up your browsers once more. If you haven't, please do so. More information is interesting and helpful. My question is, broken down into pairs, human or veterinary, so please choose the one that applies to you. If you recall your patients with hypertrophic cardiomyopathy, was the diagnosis most often made on echo, human veterinary, physical exam alone, human veterinary, other imaging like MR or other, or on histo? Histologically would be presumably either a postmortem, heart transplant, or other. Maybe another minute or two, or a few seconds rather. So thank you for those who've contributed. It's interesting that echo is far and above the top choice. There was a little bit of a trap over here by mentioning physical exam alone, only in the sense that I think the high prevalence of hypertrophic cardiomyopathy in cats sometimes leads veterinarians to suspect that if there's a heart murmur, then that's probably due to hypertrophic obstructive cardiomyopathy, because the disease is so widespread. It's a fair association to link heart murmurs with HOCM, but not an exclusive one, far from it. There's a high prevalence of benign physiologic heart murmurs in cats, and so to try and make a murmur equal hypertrophic cardiomyopathy would be potentially missing the possibility of physiologic murmurs and no disease at all. Thanks to those of you who responded there. So really, when we make a diagnosis of hypertrophic cardiomyopathy in cats, we rely on echo. And this is no different than, I think, what a typical echo would be for a person. I just had my echo last Friday, and so this is pretty much how it worked for me. What we do, and we do many of these a day, is we have a feline patient lies on the side, lateral recumbency. We take advantage of gravity to draw the heart against the chest wall, shave a little bit of hair, which perhaps is less of a common concern for you, and away we go. The big difference, I think many physicians, medical students, nurses might notice, is heart rate. So I've slowed it down a little bit to help bring some degree of familiarity with maybe the human counterpart. But cats, when they come to see me, want to be doing anything other than seeing me. And that is a cat thing. Because I'm interested in accomplishing a goal, which is to do an echo, and my patient does not want that same goal. So that typically means that a cat that comes to the veterinary hospital, even one with a fairly calm demeanor, like the examples that I showed on those 2 video clips, can be expected to have a heart rate that is 200 or more beats per minute. And that can be challenging with echo. It can make interpretation, even with high frame rates and very good equipment like we have. Even so, there can be nuances, or as you pointed out, Dr. Maron, endocardial borders can be quite challenging to be sure about. But be that as it may, this is a standard echo that shows left atrium, left ventricle, right atrium, right ventricle in a typical configuration, and this is normal. And then here's another cat where really that same kind of proportion is lost. So here we have maybe some modest degree of interventricular septal hypertrophy, and then grotesque papillary muscle and free wall thickening, leading to essentially to obliteration of the left ventricular lumen and systole. Another example, here the degree of obstruction is less dramatic, but it's more insidious because of its location. The septal hypertrophy is pronounced most at the base, which drags, or contributes, I should say, to dynamic outflow obstruction. So systolic anterior motion of the mitral valve is a phenomenon in cats, as it is in humans with this disease. And so what do we do with that? You know, we have this problem. We know that cats are affected in ways that in many ways maybe are similar to the way people are affected by this disease. What can we do about it? Well, it's true that technical limitations, and I would say cost limitations, prevent much of the invasive, essentially all of the invasive work that is available for human HCM patients. So maybe one day there will be the ability to navigate a cat's coronary arteries in a way that allows us to deliver ethanol for septal ablation. Maybe one day there will be coronary bypass systems that are small enough and accessible enough financially and technologically to be used for cats. But at the moment, that's not our reality. So let me instead walk through a little bit of what we do have and see how that holds up. There was a big question, boy, I can remember even from the early days of my own training, about whether the obstruction of hypertrophic obstructive cardiomyopathy could be well controlled with a beta blocker, a drug that blocks beta-adrenergic receptors and therefore, in my simplified way of describing it to pet owners, could act as an anti-adrenaline blanket around the heart. Like, could that be helpful? And the rationale for doing it was a very logical one. I mean, it would decrease myocardial energy consumption by capping, presumably, the heart rate of a cat that would otherwise be very excited or exercising or whatever. If we can't talk that cat into not doing those things, maybe we could give a beta blocker that would at least present a chemical ceiling to how fast the heart rate could go. And that seemed to be really logical in terms of reducing outflow tract obstruction as well as decreasing myocardial oxygen consumption. And so, fair enough. So does it work? Well, there was one more piece that made it even more provocative. The first ever survey of hypertrophic cardiomyopathy in cats was published by the North Carolina group and Clark Atkins in the early 90s. And they showed something that I have not seen repeated since, which was a difference in outcome, so prognostic significance, to whether the heart rate was lower, less than 200 beats per minute, or higher, more than 200 beats per minute, at admission. And so how interesting would it be to consider that perhaps the beta receptors are more upregulated or more numerous, or that there's some element of hypertrophic cardiomyopathy that through simply measuring the heart rate helps us stratify risk. Now, of course, this was a retrospective study. So all of that seemed like really good grounds for prescribing beta blockers for hypertrophic cardiomyopathy, and I'm guilty of having done it. I mean, I've prescribed lots and lots and lots of beta blockers to cats with asymptomatic HCM and especially HOCM, thinking I was helping them. We don't have a ton of objective information, but we do have two important studies. This one, published by Schober and his colleagues at Ohio State, looked at a pretty simple concept, which was just looking back at follow-up of cats that received it versus didn't. Now, this was not placebo-controlled, and this was retrospective, two serious flaws for any treatment study, but it's what we've got. And so these cats were followed retrospectively out for 5 years back to compare their all-cause mortality as well as their cardiac mortality. And I think these Kaplan-Meier curves kind of speak volumes. I don't even remember which one of these is the treatment one and which was the no treatment, because they overlap so perfectly. This indicates that the percentage of survival of individual cats when starting from day 0 of the start of treatment and then looked at for the subsequent years, the number of individuals that died over that time was really no different whether they received a beta blocker or not. And that was supported by a subsequent study looking at biomarkers in particular, or at least that further evidence that maybe beta blockers aren't doing much was provided by this study. So the day of using beta blockers as really a major way of addressing hypertrophic cardiomyopathy does not seem to have dawned in the feline world. I think there's probably still room for it, and I do still prescribe this when we have severe obstruction, especially if it's accompanied by tachyarrhythmias. So what about other drugs? Certainly, this article I know drew a lot of attention, and rightly so. This was an article by Dr. Roberts' group that looked at the role of aldosterone, and the title, I think, says pretty much what we need to know. Aldosterone, through novel signaling proteins, is a fundamental molecular bridge between the genetic defect and cardiac phenotype of HCM. Now, this is 2004. And so knowing that that was true, that aldosterone might play such an important role, then an aldosterone antagonist like spironolactone might be very, very beneficial. So that led the University of California Davis group to look at Maine Coon cats with hypertrophic cardiomyopathy and to treat them and to follow them very closely, to examine them before and after treatment with cardiac MRI, to evaluate what was at the time in 2008 quite novel tissue Doppler imaging, and so on and so forth. And what they found was unmistakable, that there were no significant changes, and in fact that there were adverse effects associated with this treatment. I thought it was interesting that a recent paper by Dr. Maron's group also really seemed to produce no evidence to support this kind of treatment, even though spironolactone seems to be so much more, or its congeners seem to be more widely used in human medicine perhaps than in us. Or in our profession. So if atenolol isn't altering the evolution of the cardiomyopathic process or producing any visible benefit, if spironolactone isn't, I would say the same is true for ACE inhibitors, then what do we have? How can we treat these cats? The answer is that the best treatment that we have is to implement treatment when overt decompensation occurs. So if a cat has congestive heart failure, this is the same film I showed you on the left in a previous slide, then we give furosemide, the classic loop diuretic that's been around for decades, plus an ACE inhibitor, and that becomes the mainstay of treatment. It's unsatisfying because we're dealing with the consequences of hypertrophic cardiomyopathy rather than reversing or addressing the nature of the disease, but it is what we have, And certainly from treatment response, we see that it helps our patients, it saves lives, but it's imperfect at best. We also use pharmacologic treatment in cats that have a risk of thrombosis. So I mentioned early on aortic thromboembolism, this idea of a blood clot that lodges at the terminal aorta. This is a devastating consequence of hypertrophic cardiomyopathy. It produces excruciating pain and is frequently fatal. And so what can we do to help that? And so what we have, again, essentially borrowed from the human medical field, is platelet inhibitors. And so clopidogrel is the sort of leader of the pack in this respect. It has replaced aspirin, and that work came from Dan Hogan and the Purdue group, as well as several other investigators. It showed a clear benefit to giving clopidogrel in cats that had experienced one episode of aortic thromboembolism before and were now being treated prophylactically to try and prevent a second one. Factor Xa inhibitors like rivaroxaban and others are being investigated too. So how would we know that a patient is at thromboembolic risk to begin with? Let me show you a pair of echocardiograms side by side. Here on the right is a normal cat for comparison, or at least a cat with HCM, but no left atrial enlargement. On the right is shocking left atrial enlargement with spontaneous contrast. This is a form of microclot formation that occurs when we have marked dilation of a heart chamber. It's both beautiful and gory. And here in the extreme sort of end of the left atrial appendage is an organized clot waiting to form or to embolize and create aortic thromboembolism. The problem, of course, is that we don't have a way of successfully removing that. So I'm not sure if a patient who had these echo findings would be treated invasively or non-invasively, but for us, it's non-invasively for lack of an alternative. So clopidogrel is what we have to not exactly chip away at that clot, but to try and prevent its growth. So what I've tried to do so far is to highlight some of the aspects of hypertrophic cardiomyopathy in cats that are reminiscent of those in people. The gross morphology, the histologic characteristics, the gradual behavior. Dr. Maron, to your point, how is it that 122 countries have reported humans with hypertrophic cardiomyopathy a non-communicable disease? How is it that cats have the exact same thing when this isn't contagious or zoonotic? So one day, maybe we'll understand a little bit more of the mechanisms that would lead to that kind of similarity. I hope so. In the meantime, what I thought I would point out are some of the differences that stand out to us as veterinarians as being different in cats from people. One of these is the use of pimobendan as a treatment for cats with congestive heart failure due to hypertrophic cardiomyopathy. So pimobendan is I think, little discussed in human medicine. My understanding is that I know that it's not approved for human use in North America. I believe it is in Japan and possibly some other countries, presumably for regulatory reasons. I'd love to know more from your perspective, Dr. Maron. But no matter how we slice it, this drug is a positive inotrope, it's orally administered, and a vasodilator, both exact contraindications for hypertrophic cardiomyopathy, certainly hypertrophic obstructive cardiomyopathy. A patient with hypertrophic cardiomyopathy who's a cat should not need a drug that increases systolic function and makes the ventricles pump harder, except maybe at the very end stage. A cat that has diastolic dysfunction should not need nor benefit from something that causes peripheral arterial dilation. And yet that's what this drug does. So why would we ever think that that was a good idea? And the reason we do in veterinary medicine is based on a couple of studies, the next to most recent of which is this, again, a retrospective study, so to be taken with a real grain of no salt. This is the median survival of cats with hypertrophic cardiomyopathy treated with standard therapy, and an equivalent number of cats in whom pimobendan was given had a median survival time of 6 times longer. Now, I want to emphasize this is a retrospective study with all of the trappings and pitfalls that I've mentioned before. It may be that the individuals who owned these cats and were willing or able to give this medication also provided much better care. There's many, many other reasons to suspect that there would be limitations to such a study. But I have to say that there is either there's a great placebo effect, which I'm willing to accept that I would be prone to, or there are individual cats who seem to respond to this in ways that would be unexpected with standard therapy. So why would this drug work in that kind of setting? Anybody's guess. Some have speculated about systolic dysfunction occurring in terminal or end-stage hypertrophic cardiomyopathy, and this does seem to, in my completely biased experience, seem to work better in cats that are worse off. Could there be other effects? The antiplatelet effects of pimobendan were examined and are not, for any practical purposes, are non-existent in the cat. So could there be something else? Perhaps. So that's one big difference between cats and people, is that we routinely consider this. There's been preliminary reports of another prospective clinical trial that are more sobering, that specifically show that this shouldn't be administered in obstructive disease, which makes sense, and are intriguing for non-obstructive disease, waiting for the published results. So other differences. Dr. Maron, you alluded to this earlier. The principle of hypertrophic obstructive cardiomyopathy is the idea that the process of emptying the left ventricle runs into an obstruction or interference from physical narrowing of the outflow of that ventricle. And we know that in people, as Dr. Maron's pointed out, this constitutes a very substantial reason for symptoms and for impaired quality of life and mortality. In cats, shockingly, there is no difference in either the onset of clinical signs or cardiovascular death or survival, or even the duration of time from diagnosis to the onset of overt clinical signs in cats that have obstruction versus those that don't. And that would seem really counterintuitive. It should be that two cats who have the same amount of ventricular hypertrophy would not evolve in the same way if one of them concomitantly had difficulty moving blood out of its left ventricle. So why would this be? And one thing that's been speculated is that hypertrophic obstructive cardiomyopathy probably leads cats to be diagnosed earlier in the disease process because they tend to have murmurs. The way that I know that one of my patients might need an echocardiogram, the way that I would think of ruling out or ruling in hypertrophic cardiomyopathy has to be something. And the most common reason for that, if there are no overt clinical signs, is the auscultation of a murmur. So what I'm getting at is that the occurrence of a heart murmur as produced by hypertrophic obstructive cardiomyopathy, and as distinct from non-obstructive disease, which can often be silent disease, that might be what leads us to identify HOCM earlier in cats and therefore earlier in the disease process, so to have it associated with what turns out to be a better prognosis. You know, it's a funny thing. My understanding of hypertrophic obstructive cardiomyopathy in people is that it's an important driver of exercise intolerance, so exertional dyspnea, exertional symptoms. In a cat, that's a little bit tricky. So this is what one of my patients looks like in terms of exertion. And I can say from my early days as a veterinarian that a good way to not inspire confidence and kind of faith in a cat owner is to ask them about exercise intolerance as part of the medical interview, because the answer is, you know, typically something like, well, doc, he sleeps 23 hours a day. How much more exercise intolerant do you want him to be? So I will say I learned that the hard way. So for a long time, I guess I thought that exercise intolerance was just sort of, you know, not applicable to cats. But it's worth remembering that cats anatomically are obligate nasal breathers. So there's an MRI of the head of a cat. brain up here, tongue here. This is the soft palate, and the soft palate's rather long, and the larynx of a cat overlaps with it, so cats tend to breathe in and out of their nose. And you might have noticed that even the one video clip of a cat that I showed had the cat's mouth closed, even though the cat was breathing pretty hard. So by the time a cat breathes with its mouth open, then that almost invariably means either anxiety, like driving to come to see me, or true dyspnea. And that's important because now, in thinking about it in hindsight and being maybe a little bit more in tune to it, I do feel that we know there's a subset of cats that clearly demonstrate exertional dyspnea, but it takes work for the owners to notice it. Sometimes the cat's mouth is only open a little bit. And so when would that happen? It happens when they buy the laser pointer. And so this is what exertion looks like in a cat. And when a cat has this kind of vigorous exercise, and the owner says, or I ask, and does your cat pant like a dog afterwards? And the owner of the cat says yes. Then I think, okay, so maybe that is exertional dyspnea and a manifestation of obstructive disease. That would be a cat where I would recommend either get rid of the laser pointer or start atenolol or both. But perhaps there's better pharmacologic ways of addressing that. A third difference. So I spoke about the role of pimobendan. I spoke about HOCM versus HCM. The third difference in cats is that, unlike people, the role of arrhythmias is very minor in hypertrophic cardiomyopathy in cats. We have very limited information. There's two papers I was involved with, one on atrial fib and one on ventricular arrhythmias. They indicate and they suggest that cats need to have extensive disease before showing arrhythmias. And we could probably presume that part of that would be because a cat heart is small, and so a critical mass of atrial myocardium that is needed to perpetuate atrial fib, for example, would probably be, would almost necessarily require atrial enlargement. That seems to be true based on the fact that if you have atrial fib in a cat without atrial enlargement, it is a publishable event. So this is one of the rare cats that was documented to have atrial fib without atrial enlargement. And now I'd like to point out a fourth characteristic that's intriguing that represents a substantial difference between feline hypertrophic cardiomyopathy and human hypertrophic cardiomyopathy, and that's an imposter called transient myocardial thickening. Dr. Maron, I think you might not be aware of this, but you have a role to play in this in the following way. I think it was about 6 years ago that you gave a state-of-the-art talk that I had the privilege of attending, and a question came up from the veterinary side about what about human hypertrophic cardiomyopathy patients who have hypertrophic cardiomyopathy and then they just normalize spontaneously? And your comment at the time, forgive me if I'm putting words in your mouth, was that that doesn't really happen, short of ischemia that would cause fibrosis, but that spontaneous regression of hypertrophy was not really something that was a recognized or common feature. I'd love to hear an updated version. And I remember thinking that was surprising because I knew that I had seen that kind of situation before. And the difference between me as somebody who is really intrigued by it and Dr. Virginia Lewis-Fuentes, who is a brilliant investigator at the Royal Vet College, is that she actually investigated it. So those results were published last year. This name that's been given, transient myocardial thickening, refers to ventricular thickening that would be mistaken echocardiographically for hypertrophic cardiomyopathy, but that just goes away. And so what does that mean, or what does this study look like? These folks looked at, they found 21 cats, which I think is quite impressive, because I've never felt that this was a widespread problem. But I know that here we must see 1 or 2 cases of this a year, and we just don't understand why it happens. So the study drew on 3 institutions and corralled 21 cats with a left ventricular wall thickness greater than or equal to 6 millimeters, which would be our upper cutoff or our threshold for hypertrophic cardiomyopathy, and congestive heart failure. If both the thickening and the heart failure went away by themselves, then that was called transient myocardial thickening. Whereas if it persisted, then that's garden variety hypertrophic cardiomyopathy. So here are some examples that were published directly from that paper. These mimic my experience, but the pictures are much prettier. So here's a long axis, 4-chamber, right-sided parasternal long axis view of a pretty thick left ventricle, short axis, similar thing. 7 months later, it's gone. Similar sort of thing on a different case, thick, and then not, and not. And so, how can this be? They found that some features that were common to these cats with this disappearing hypertrophy was that they tended to be younger. The mean age was 2 years compared to a mean of 8 for the others. They presented that this having been a retrospective study, they had treatment follow-up information, and they were able to discontinue cardiac medications, heart failure medications, basically, in essentially all the cats with transient myocardial thickening and none of the HCM cats. And importantly, there was no difference in heart rate between the 2 groups, because one might speculate that if one group was more tachycardic than the other and at these heart rates, maybe there wasn't enough time to relax, and that created pseudo-hypertrophy in one versus the other. But that wasn't the case. I remember seeing the first case of this. It's interesting. It was published just last year. I remember my first case very well. It would have been in the late 90s when I was in Los Angeles doing my residency at California Animal Hospital. And I remember we had a cat who had hypertrophic cardiomyopathy who came back for his recheck. And I'd started the cat on atenolol, and we repeated the echocardiogram. And was I ever proud to see that the thickened left ventricle was now just about back to normal. And I went to tell the owner afterwards at the time of discharge that I was so pleased to see that this particular cat was responding to the atenolol because we should absolutely continue it. To which the owner said, "Oh, I meant to tell you, we never filled the prescription. Do you think we should do it and start it?" So much for my grand conclusion. But there it was. And so this is, I love the saying about when disorders are further investigated and new knowledge emerges, the saying that, maybe I've never seen it before, but it's seen me. And that was certainly an example of that. So with transient myocardial thickening, there's been speculation about could there be a role of myocarditis. Here's a case report in a cat who had left-sided congestive heart failure, had was seropositive for Bartonella. That has, a rather questionable value because Bartonella is so highly prevalent in cats. The specific pathogenic role of Bartonella is open for discussion and speculation. The cardiac troponin levels in this cat were sky high. Normal would be in the sort of 0.04 to 0.08 range. The cat was treated with azithromycin, which is considered a treatment for Bartonella, and heart failure medications. And 6 weeks later, the echo had normalized. There was no more hypertrophic cardiomyopathy. Troponin levels had normalized. All treatments were stopped, and the cat was fine. So I think overall, if I look back at substantive differences between feline hypertrophic cardiomyopathy and human hypertrophic cardiomyopathy, these are some that stand out both in terms of basic management, but also in terms of an imposter syndrome like this one. And I'd love to know a few years on if this ever happens, or maybe if the echo now shows normal where 5 years ago in this person it was abnormal. Maybe you think it was just an echo error. Maybe this is still not a thing. So in closing, I have a couple of questions that to me kind of really embody the challenge of hypertrophic cardiomyopathy in cats. And it sounds maybe absurd to simplify it like this, but I'd like to know what it is. We know that it's ventricular thickening. We know that it can cause these problems, but sure, it's associated with gene mutations, but we know that's not the whole answer. And so to me, the way that it evolves being so variable makes it difficult well, we know that it's difficult to predict, to understand. So I would like to know more about what is this? What are the answers that explain this variable progression, variable response to treatment? And so how can we predict which cases accelerate quickly and which ones stay stable indefinitely? In veterinary medicine, we have euthanasia. And so it may be that an individual whose cat has relatively mild hypertrophic cardiomyopathy wants to avoid future suffering and may wish to do that or may lean in that direction unjustly. So we need to know for our patient's benefit what accurate risk stratification looks like. And then finally, is there anything medical of use other than clopidogrel for thromboembolic prevention and heart failure treatment? It would be nice to continue those developments. More questions than answers, perhaps, but I'm mindful that we have covered good territory. Before coming here, I worked at Angel Memorial Animal Hospital in Boston, and while I was there, I shared an office with Neil Harpster, who's another giant in veterinary cardiology, and he had I think an experience and a memory that was quite encouraging. He said, don't forget that when I went to veterinary school, we covered feline cardiology. It was very clear and very quick. So he graduated in 1968, or at least he got taught feline cardiology in 1968 in veterinary school. And he said, we actually covered it in one sentence. He said, cats don't get heart disease. Like, that's what was known in 1968. And so, now that we're some ways on, and 10,000 unique literature references and sort of individual publications and various breakthroughs is not a ton, but it's a lot better off than we used to be. So with that, I'd like to once again thank the individuals who have made this session today possible. I want to thank you all very much for your attention, and I would welcome any questions.
Thank you very much, both of you. So if any of the live audience has questions, I guess I would encourage you to make your way to the microphones. Dr. Butler.
I'd like to direct this to both of our panelists.
We'll give them a moment to get down here. Thank you.
I'd like to address this to both of our panelists, and that is your map of incidence, Dr. Maron. Curiously, it was white throughout particularly Eastern Africa, and of course Greenland, which perhaps explains why we're trying to buy it. But the other thing, and this is directed to Dr. Côté, is we hear these papers coming out from Canada and the United States. Is there a equal incidence elsewhere in the world, as far as you know, of feline cardiomyopathy?
Yeah, we're good.
Microphones.
Oh, yeah, I have the mic. Yeah, that was Central Africa. There was constant civil war in some of those countries. There's no way to get any information like this. They don't have it or publish it or anything. So I don't, I think we'll probably never know if some of those countries have HCM. But I think, the implication was that we found it just about anywhere where there was information, that it's probably everywhere.
From the feline side, we do know that studies throughout Europe, from Japan, Australia, South Africa, consistently show that hypertrophic cardiomyopathy is prevalent. After leaving Boston on my way to Prince Edward Island many years ago, I had a wonderful 6-month stint teaching at the University of Pretoria in South Africa. And I would say that what I saw there was indistinguishable from what I see here or in the US. So I think maybe along similar lines that it's not whether it's there or not, but whether we're seeing it. And the role of cats in society is highly variable around the world. So there are surely many where we don't get to look.
No, I'm fine.
Yeah, just to follow up on that a little bit, I do find it remarkable that HCM is present across so many different human cultures with different genetic makeups. So when it comes to cats, what about other felines, first of all, and then what about the canines and the ovines and the caprines?
Yeah, so this, I mean, Dr. Maron, your knowledge of comparative cardiology, I'd love to hear it. I mean, what I know is that I believe one of your first papers with AMC group included pigs and dogs and cats, maybe with Larry Tilley, but maybe not. So why is it that it's in domestic cats? This is something that I believe has been documented in occasional large wild cats, but occasional. This is something that is just not widely prevalent in other domestic animal species. So why? We need to know why it happens. I don't. But speaking of genetics, though, there are different prevalences within different cat breeds. So within the domestic cat, for example, ragdoll cats, Maine Coon cats, Sphinx cats, Bengal cats, have a much higher prevalence than domestic short-haired, which are your sort of everyday street cat. Yeah.
So HCM doesn't occur in dogs.
I mean, it does very rarely.
Yeah, that thing about the pigs is not reliable. That happened to be data that was made up, unfortunately.
Okay. Was it, they weren't bred to be affected or anything like that?
It was one of my strangest trips to Taiwan with Phil Fox. And there was a lot of pressure there. It's a long story, there was a lot of pressure there, but we stayed several days, and Phil actually echoed an enormous pig who, had to be anesthetized, and it was dangerous and all that, and came out with a wall thickness of 9. So, in the end, we left saying that these pigs in Taiwan do not have HCM. That was the conclusion. And then, unfortunately, about 6 months later, I saw a paper that came out of that experience that I hadn't seen, said that the pigs had HCM. So it's one of those kind of things. It's a sad thing. And it's not true. It's not true. Or at least there's no evidence.
To both of you, thank you for your presentation. I retired a couple of years ago after about 4 decades in an adult clinical cardiology practice. So my career would have overlapped roughly that 4 years or so that Dr. Marion discussed. I find it very interesting looking at your last slide when you talk about the fact that people don't die of hokum. That can be extrapolated, I think, to adult cardiovascular disease in general. People no longer die in heart failure. If I could take my practice over the last decade or so, you could put it into 2 categories. The men with heart failure live long enough to get cancer, And the women with heart failure, unfortunately, live long enough to develop dementia. And by the way, Dr. Côté, we were taught in the 60s too that women don't get heart disease.
Right.
Yeah, so we're sort of diminishing sudden death from HCM with the penetration of defibrillators, okay? Atrial fibrillation, the only cause of death is non-compliance with the new agents for a fatal stroke. And then that kind of leaves, heart failure due to obstruction. No one should die of obstructive HCM with ways of eliminating the gradient. And that leaves us with non-obstructive HCM, which are your transplant group, whether they get listed, don't get listed, die in the course of the whole process. That's about it. Patients with unrelenting severe heart failure without obstruction. It's kind of remarkable, but that's the one group for which there is mortality, this disease. Since we're similar ages, then we think back about what the whole thing was like before. And to witness that in the course of one, professional career is kind of an interesting experience. Very few patients should die of this disease at this point.
Did you have a question next door or no? Sorry, I thought I saw you with the microphone. If I could ask a question, maybe one last question, unless you have any questions come in through. Okay. Dr. Maron, you gave a really eloquent view of an algorithm that identifies patients at increased risk of cardiac sudden death. And as Dr. Côté alluded to, in our world, thromboembolism is a devastating complication. And so beyond identifying the cat with the gigantic left atrium and spontaneous echo contrast, are you aware of, are there any, predictors of embolic stroke in people with HCM that we could maybe look to help us predict who are the cats that are going to embolize, because they're not always the ones with the giant left atrium and the smoke.
No, it's tied to atrial fibrillation, which is a very common arrhythmia. That's where the embolic strokes are.
That's really interesting because ours are not.
Yeah.
So yeah.
Okay, so that's one area where they diverge, I think, very clearly. It's all about the timing to start anticoagulation, and we have very low thresholds. So one episode of real atrial fibrillation is enough to recommend anticoagulation. And of course now you don't have to worry about all the problems with warfarin. So these NOAC drugs make it really easy. And I think that, eventually, if not now, the risk of embolic stroke in this disease will be obliterated. There'll always be exceptions, of course. You can't eliminate everything. But, we're witnessing an era where contemporary treatments really do alter the natural course of a disease that's been so difficult before.
And I think that's really inspiring for those of us that feel like with the little that we do that we really don't make much of a difference at all. So I think you've given us information that is that we can aspire to, really. So thank you for that. And at the same time, humbling information that makes me feel like we're not alone when you use words like unpredictability and heterogeneity and uncertainty. And I think that's the way we feel a lot too with some of our patients.
Yeah. Well, they're all true, but also the treatments are powerful. So that overcomes, a lot of that. The decision making for a lot of these patients is tough, but I showed you the Tufts data, 17 years of making these decisions. It's possible with good clinical judgment, plus the risk markers. Okay, so you start with the risk markers. The way we do it, one major risk marker, major in the context of a patient's clinical profile. One of those that I showed you, syncope, unexplained syncope, family history of sudden cardiac death, massive hypertrophy, those markers, if one or more is enough to strongly consider a device. But, we're dealing also with patients, and there's shared decision-making, there's clinical judgment, because there's a lot of variables. I mean, age becomes a variable. You can have as I pointed out, you can have the risk marker, but we may ignore, a given patient who's 65 or 70 and stable. How do you become high risk for the first time at 70, get an ICD implanted because you had a family member die suddenly of HCM? It takes a lot of, I think, clinical skill to make the thing make sense. Yeah. All right. So it looks very easy there, but nevertheless, it's a clinical challenge. I think, the thing that really stands out there is that the data are amazing, that hardly anybody died with that process. Sudden death has been the one thing that, has been the unpredictable concern, patients and clinicians together. And, remembering, though, that there are some cultures among the 122 countries where you can't really practice the same way right now. This is to show what's possible for HCM to eliminate or suppress sudden death risk. But, with all the insurance problems and all the economics and all the cultural obstacles in places like India and China, who have all the patients, really, it may not be possible to do these things. This is for North America, right now, North America, Europe, Australia, New Zealand, places like that. But it's going to change. It's just a matter of time.
Thank you. Thanks. So I think, there's one last question. One last question.
But to record, if you could.
Just run over to that one, if you don't mind.
Hello. Yeah, good. So I'm a cardiology fellow in early stage of my training, so I have, I think, a lot to learn about HCM. But on day-to-day clinical practice, I think my biggest worry is how to identify those cats. So for cats, for example, we have the cutoff of 6 millimeter for diagnosis, and Dr. Maron, as you mentioned about the cutoff in humans is 15 millimeter of wall thickness. So I wonder how you follow the patients who have like 10 to 15 millimeter of wall thickness. Do you recommend to follow up or look for other risk factors in those patients?
No, I was pointing out that the spectrum seems to get bigger and bigger. Every time we think we have seen all the subgroups, we haven't. And recently, all of a sudden, I don't know exactly how this happens, but all of a sudden, meaning over, let's say, a 2 to 5 year period, we assembled a number of patients that presented with severe heart failure from obstruction, who might have 14, 13, 12 millimeter wall thicknesses. Can't find it in the literature, and you can now, but at that point, early on, no. It's almost as if the disease changes, I don't know, or the referral patterns change, one way or the other. But the idea of dynamic obstruction producing severe symptoms, New York Heart Class 3 symptoms, in the presence of marginal wall thicknesses was not something that I remember from 20 years ago. But, you know, in this case, it becomes operable because we have surgeons now who can do things to the mitral valve. Obviously, there's not much muscle you can take in terms of septal myectomy. So it's not really a myectomy patient. They take a little bit, we shave a little bit, but they remodel the mitral valve. They may plicate the mitral valve, which was something we talked about as an idea for small animals. You know, plication means just one stitch. The mitral valve, anterior leaflet, deadens its motion pattern and won't touch the septum. That's been performed in patients for many years, selectively. And, you know, the results of, I think there have been 35 patients operated on now who fall in this group of mild or no hypertrophy and dynamic obstruction and severe symptoms, have been excellent. You got to have a surgeon, though. You got to have a good surgeon. That's what that comes down to. So I don't know. We were talking the other day. All of a sudden, there was a recognition that the wall thicknesses of the patients seem to be less. The maximum wall thicknesses, you know. We published many times 21 to 22 millimeters would be a mean of any group. We're going to have to look at that in detail, but it doesn't seem like it's true anymore. Looks like it's somewhere around 17 or 18 for average for maximum thickness. The age of the patients is definitely increasing. That's a referral issue, I guess, in some ways. So the demographics seem to change as well, right before your eyes. It's it's like that. I don't know what all the explanations are. But the spectrum is so broad and wide. These aneurysms, you know, we hadn't identified those until, I guess the first paper is something like 7 or 8 years ago. So all those patients over all that time, where were the aneurysms? Well, the MRI mattered. All the patients get an MRI now. So the testing then can have an influence. And all of a sudden, I think we have 130 patients with left ventricular apical aneurysms, where just a few years ago, there were 0. Another emerging risk marker. You've really seen that? You didn't say anything about that this morning.
I mean, well, we got tonight.
That would be incredible.
That's true. Yeah, paper thin.
At the apex.
Mm-hmm.
With a scar.
I mean, there's no myocardium there.
Yeah, but sometimes they die, so you have a...
That's how we know.
Okay, well, that would be another connection.
Okay, thanks. Thanks very much. So I think first and foremost, I would like to sincerely thank our speakers today for such informative and engaging talks. And I can only imagine the number of engagements that you are asked to do. And so just for you to be here, we're so very grateful.
You're welcome.
I also want to, again, thank the Butlers and the Pegasus Family Foundation for supporting this endeavor. And of course, everybody in the audience, thank you for coming. Thank you for joining us. And I believe there's some refreshments outside, so please join us. Thank you again.